Good morning. Boy, this microphone is very sensitive. Good morning, everyone. We're still starting to stream in, but we're going to get started. My name is Rachel Chapin Cohen, and I'd like to welcome you to day 2 of the National Research Conference on Early Childhood. I hope those of you who are in the room had a thoughtful and productive day yesterday. And we'd like to make a special welcome to those who are watching online. This is our first foray into live streaming, so we are very excited to welcome you. So our plenary this morning is entitled Universal Home Visiting, Evidence of Impact. And while most of the presentations you're going to hear at this conference are about targeting services to those most in need, usually based on income, in fact, one of the mission statements for this conference is stated for this conference to have a primary focus on young children from low-income families. This session is going to be a little bit different. So the 2 speakers we're going to hear from this morning are going to share information on programs that take a different approach. Both Durham Connects and Welcome Baby are programs that take a universal approach to providing home visiting services based on more of a public health model where voluntary services are provided to all those in the community who would like them. This approach to getting intensive services to those most in need, not based on demographic factors like income alone, but on a more fuller assessment of needs, is getting attention across the early childhood field. And it is appealing because it has the potential to be more cost-effective, allowing each family to receive services that would be most helpful for them, while also limiting the stigma of receiving targeted services. This approach also necessitates very strong community commitment and collaboration across agencies, which I'm sure we'll hear more about this morning. The speakers today will describe the development of the 2 programs and lessons learned through their early years of development, and will also share data on what we know about the impacts of the programs. Both of them have very robust research components. First, we're going to hear from Ken Dodge, who is the William McDougall Professor of Public Policy at Duke University, where he directs the Center for Child and Family Policy. He will share findings on the Connects program. Then we'll hear from Barbara DuBransky, who's at the end of the table here. She is the director of First 5 LA's Program Development Department. She's been with First 5 LA for 15 years and has developed and implemented many programs, including Best Start LA, its signature place-based investment, and Best Start's home visiting components, which include Welcome Baby, that she's going to talk about this morning. Then we're fortunate to have as our discussant, Deborah Daro, a Chapin Hall Senior Research Fellow at the University of Chicago, who will pull together the themes across the 2 presentations and talk about the implications of these universal approaches for other home visiting programs and the broader early childhood community beyond home visiting. We're going to save our questions for the very end of the presentations, and I'd like to welcome Ken up.
Good morning. Thank you, Rachel, for the introduction. Thanks to Deb for organizing, all of you for being here, and to the organizers of this conference for devoting a plenary to this topic. I want to talk with you about universal support for families of newborns. Home visiting is a part of it, but it's really about universal support for families. I got into this field about 15 years ago when I interacted with the Duke Endowment, which had a strong interest in changing community rates of child maltreatment, preventing child maltreatment, particularly in the first several years of life. And they were willing to make a 10-year commitment to us financially to support our work so that we would have the opportunity to fail and learn from our failures and then move on. The requirements in the agreement that we had with them were, first, that we develop a replicable model based in developmental science with a very rigorous evaluation of impact. So I'll talk with you about a couple of randomized controlled trials, where the target is the community rate of maltreatment and child well-being as the outcome variables. So what we did was to engage in a lot of planning and community collaboration. One of the first things that we did was to join with Durham, North Carolina community leaders, elected officials, community professionals, etc., and begin research as well, a longitudinal study that we began of 500 pregnant women to follow them through birth and into the child's first several years of life to try to learn. We piloted several interventions, some that failed, and then we, after about 8 years, were ready for prime time in a randomized controlled trial, community-wide randomized controlled trial, where every baby born in Durham, North Carolina was a part of the trial. And now we're replicating that and disseminating. So the first thing that we learned in our longitudinal work was that the risk factors for early child maltreatment vary across families. Some of that variance might be due to socioeconomic status and income, but the majority of the variance is not. Risk occurs at every income strata, in every form of family kind of background. And the risk factors also were quite diverse. We identified 12 different risk factors in domains of healthcare, access to healthcare or lack thereof, in parenting and child care, plannings, parent-infant relationship, the parent's management of infant crying early on, family safety, whether it's family financial instability or family violence in its various forms, and history of parenting difficulties, and of course parent mental health early on in depression, substance abuse, emotional support. So what we wanted to do was to make a paradigm shift and move toward universal delivery, where we could reach every family with a newborn baby in the Durham community, to approach them, to interact with them, to try to identify their needs and to support them. We learned every family is vulnerable at birth in different ways. So in our first year of experience of working with families, we identified 94% of all families in Durham had communicated to us a need in one of those 12 areas. I don't know if you remember when you became a parent for the first time. I sure did. I had a lot of needs. It was a very scary sort of experience, right? So we found 94% of families in Durham had a need for some kind of educational or community resource. We were able to accommodate those needs and resolve those needs for about half of the families fairly quickly. Some were, where do I get the best child care? Or how do I manage infant crying and stop worrying about it? We were able to manage about half of those. With the remaining 45% or so, we referred to ongoing community resources to carry the load of the ongoing need of the families. So this is a very time-limited, short-term home visiting program. All right. Realizing that 94% of families are in some sort of need, we quickly realized universal is the best route to community-level change. And so we developed this universal program. Now, universal efforts should not replace and do not go away thinking that we're saying we're going to replace the more intensive targeted programs, but they complement each other. So in the Durham Connects program, we think about our nurses being the pediatricians or family practitioners of well baby care in the psychosocial realm and the family need realm. And that pediatrician or family practitioner certainly works with the neurosurgeons and the urologists and the specialists who might provide substance abuse treatment or more long-term infant home visiting, such as Healthy Families or Nurse Family Partnership, right? But we're really the universal approach. All right. Important part about the model of universal parent intervention is that there are really two different components. If we're going to try to reach every family and connect maybe half of the families in a community with a community resource, we need to work with the community resources. This is a fundamental difference between a universal approach and a targeted approach that might reach only a small portion of families in a community. As a clinical psychologist, when I used to work with families in a one-on-one way, I would help my families deal with the community, right? In a universal approach, I can deal with the community directly, and then the community can help families. It's a fundamental difference. So the first part of the model is a top-down policy for community resources, which we've called a preventive system of care, in which we try to identify and align the community resources that serve families of newborns or families birth to age 5 in the community. In Durham, we now have a computer data bank of about 350 community agencies that serve families, from child care agencies to professional mental health services to informal parent support groups, etc. So then this top-down policy also needs to put into place a way to reach all families, and we've been able to align with the health department and with the hospitals in a community that deliver babies. The second part of the model is a bottom-up practice with each birthing family, where we go into the home. We actually invite ourselves into the home, make it there, spend a couple of hours assessing the family's individualized needs in these 12 areas. We do brief interventions when possible, motivational interviewing if there's a need to help the family get connected to a community resources. So the goal is to improve that community connectedness. So how does this universal program happen? So every family with a newborn in the identified community is eligible. So for us initially it was the community of Durham County, North Carolina. It might be a city, it might be a neighborhood in a larger metropolitan area, or a health system. It's a voluntary program, all right? So we approach families, but it's completely voluntary. We work to align the community resources with input from the families about the care and the support they need. By assessing the universe of families in a community and then aggregating those results, we can help communities identify gaps in their local system of care. So one of the first things we learned in Durham was that there was a greater need for professional mental health services for mothers of newborns for both depression and substance abuse than there were numbers of beds or slots in the community agencies. So we could go to the community leaders and say, there's a need here, right? Another kind of need after visiting families was we were finding out why families weren't coming to well baby care at Lincoln Community Center, a community clinic in a lower income neighborhood, and learned that the reason was that the bus stop wouldn't go through the housing projects. So we went to city council and we got them to change the bus routes. Then the mother said, but I've got this baby and it's too expensive to walk all that way, and so Durham Community developed a policy whereby if you get onto a bus with a baby, you can get on for free. So you can see the kinds of community policy and community resources that can be marshaled that you just can't do if you're working with only 50 families in a large community. All right. The model is not all that complicated. There are 3 steps. First step is that we connect with every family, 3 to 7 contacts. We go into the hospital. In Durham, there are 2 hospitals that deliver 93% of all babies in the community. We recruit there 1 hour after birth. We invite ourselves into the home by a public health nurse, usually at 2 or 3 or 4 weeks of age. Screen, assess the risk factors, quantify that risk. So we connect with the family so that we can go to the second goal, which is to connect the family with the community as needed, both professional, paraprofessional, and natural resources, so that then parents can connect with their infant, and that's the primary goal, right? We're not a replacement for parenting, we're not raising the baby, we're really supporting parents in doing their connection with the baby. So there are these 3 components that I want to talk about briefly, each of them: the community alignment, the home visiting, and the data and monitoring. So the first part is our community alignment. I've described it as the preventive system of care, which is the context for Family Connects. So what we do is we identify existing services supporting child and family needs, as I said, ranging from housing to mental health services to early intervention, professional services, medical services, child care services, etc. Bring those leaders together. We began in Durham at the highest levels with folks like the mayor and the chair of the county commissioners and the head of the community mental health center and superintendent of schools, chief officer of the courts, the judge, and got them aligned. We then created a second-level board of practitioners for all of those. And we established what we call an agency finder for Family Connects, program implementation and documentation. So as I said, in Durham, it's about 350 community agencies. We identify the service delivery gaps so we could feed back to the community and the key stakeholders. And we've identified key stakeholders in the community to be part of our ongoing advisory board. All right, so as I said, we have a community advisory board, which allows for the assessment of the community readiness certainly prior to program installation. So as we disseminate this program to other communities, one of the very first things that we do is to try to understand community readiness and the community resources. And we've gone to different communities by now and have learned that each community is different. In Durham, Durham's an interesting community of about 300,000 people. There's high needs for sure, but there's also high resources because of the universities and the Research Triangle Park, and the professionalism. When we go to rural counties in eastern North Carolina, those professional services just don't exist. But instead, there's a network of informal peer resources, whether it's the Rotary Club or the church or some community group. There's different kinds of resources. So we have to identify those and work with those. So the community board also, advisory board also acts as a form of a formative evaluation as we're going along. We can go to a community agency and say, how come our mothers are reporting that there's they show up and it's a 4-hour wait before they get seen? Can't you have some sort of system of appointments, right? Or they feed back to us, you're giving us the wrong kinds of mothers. We serve this mothers with this problem. You're giving us mothers who are more deeply psychologically impaired, or whatever it might be. So we have this ongoing way of iterating and improving. It's also a way to foster the community buy-in, and it's truly, I think, a community-owned program. All right, moving on to the nursing interventions. The nurse engages the mother, hopefully an hour after birth, in the hospital, schedules a home visit, begins with about a 20-minute visit in the hospital, saying things like, congratulations, welcome baby into the community, we're thrilled and delighted, we want to support you, we know that you can be successful, but one thing we've learned is that no family is successful alone, and so we want to get you connected. We do then an integrated home visit where we assess those risks and needs. We do follow-up visits as needed. It's about $700 per family, community-wide, with about up to 7 visits or contacts. A month after the case is closed, we do a follow-up phone call to see if the community connections that we've installed are sticking, and if not, we might start over again. Here's the family support matrix. These are the 12 areas of risk domains that I described. We have the nurse quantitatively score risk in each of those domains in a very simple system. A 1 is this family's doing great, there are no needs. A 2 is there are modest needs that are assessed and identified in the visit that the nurse can help resolve. Like the mother says, I don't know where to go for childcare, but I need to get back to work. The nurse teaches her about North Carolina's 5-star licensing certification system for child care agencies, and they go on. A 3 is that a community resource is needed and an ongoing referral is made. A 4, thankfully, is used very, very rarely, but it's an emergency. We need to call 911 or get the police here or get the baby into the hospital or whatever. Hardly ever happens, but you have to have that possibility. All right, let me move on to data and monitoring. We document clinical encounters by having access to electronic medical records. This is something that we've been able to do in Durham. We're very fortunate that we can access the pediatrician records, we can enter them, we can learn from them and communicate with the pediatrician that way. We can monitor program components also for quality assurance. It's all electronic. And as I said, this is a way then to aggregate family needs and risks across the entire community to identify community needs. Let me tell you about the evaluation. So our first evaluation was a randomized control trial in which we randomly assigned every baby born in Durham, North Carolina, resident, by even or odd birth dates. If you were born on an even numbered birth date, you were randomly assigned to the intervention. If you were born on an odd-numbered birth date, we didn't approach you. You were in the natural control group and got services as usual for that community. We analyzed by intent to treat by reviewing administrative records. So we could go to the hospital records and look at even-numbered birth dates versus odd-numbered birth dates and see whether there are differences. I could be dead and gone at age 18. Somebody in Durham can find out whether the even-numbered birth dates have a higher graduation rate than the odd-numbered birth dates for births born in this 18-month period. It's a very transparent way to evaluate, a way not to rely on informed consent, because we can do this with de-identified data that clearly pass our IRB standards. In addition, we randomly sampled a sub-sample so that we could go into the home and do more detailed assessments of parenting quality and child development. We've replicated with a second randomized trial and then a third field quasi-experiment. Briefly, the implementation. We had what we believe to be pretty high penetration. 80% of all the families giving birth in Durham agreed, whom we approached, agreed to participate. So this includes even those difficult to find families. Of those, 86% actually successfully completed this short-term program. We had high fidelity to the protocols. We have an independent rater rate the nurses' performance and the nurses' ratings and the risk factors, and so those measures are pretty good. And then finally, as I said, 45% of families, 94% show some need. About half of those we resolve. 45% of all families show a need for community resource. Let me get to some of the findings now. Since the first goal was to improve community connections, by age 6 months, we measured the number of community connections that families of even birth dates and odd birth dates had, and we have a modest but a significant increment for the yellow bar, those randomly assigned to receive the intervention. So we're doing the proximal goal of what we wanted of connecting families. Here's some of the other impacts at age 6 months. Mother interviews, mother reported more positive parenting behaviors for the intervention than the control. Experimental condition blinded observers came into the home and watched mothers interact with their babies and rated them as having higher parenting quality. When families put their baby into child care, the quality of that child care, as rated by the 5-star licensing certification, is higher for the intervention than control. We did not have an impact on whether a family places a baby in out-of-home child care. That was not a goal. That's a family's decision. There was no impact on that. But if they did place their baby in out-of-home child care, it was of a higher quality. Mothers rated the fathers as being more involved in the father in relationship better. Observers rated the home safety better, and mothers' clinical levels of anxiety came down. Here's one of the more important slides. This is the mean cumulative number of emergency care episodes across the first 12 months of life, taken from the actual hospital records. The red line are control families, and the yellow is the Durham Connects families. And you can see that there were no differences, obviously, at the beginning, but that in the first 6 months, there's a 59% reduction in the use of emergency care and overnights in the hospital. But even after we're well gone, now the families are on their own in the community, in the second 6 months there was an additional 31% more reduction. This leads to dollar savings. You might ask about whether these findings hold across different kinds of groups of families, so we examined that pretty closely. I've got graphed here on the left side are families that were called low risk based on birth outcome. We have a positive effect for those families. For the higher risk families, we have an even higher effect, but we have a significant effect for both groups. We have a positive impact on both privately insured families as well as Medicaid families or families with no insurance. We have a positive effect on majority families as well as minority ethnic status families. We were a little bit worried that we might be preventing families from going to the emergency room when they should go, and we were denying them access to health resources. So we follow them out through 24 months of age, and you can see that there's no rebound effect. We're not simply delaying or deferring emergency care that will inevitably come. So the findings hold up at least across that time. Finally, the last data slide. These are Child Protective Services reports obtained from the state registry, so these are official reports at age 48 months, and you can see a 36% reduction in investigations for child maltreatment. All right, benefit cost analysis, I'll go over very briefly. The most important number is that for every dollar that we invested in the Durham Connects program, by age 12 months, we saved over $3 in emergency care costs and overnights in the hospital. That's a lot of money for a community of Durham size. Could be up to we thought $7.5 million were saved a year. We're now disseminating the program. It's the McVie approved program at this point, and we're disseminating to sites across the nation. The blue dots are where we are implementing the program today, and the yellow dots are where we have active plans to disseminate. The dissemination is occurring and being implemented in various ways in these different sites. Some health departments, some nonprofits, 2 for-profit healthcare systems have decided to implement the program as a free service to the families that they serve because they realize it'll save them money. I'm going to close with some lessons learned that might be topics for longer conversation. The first is that universal penetration is possible if you do this with this combined top-down as well as bottom-up way. It's important that this program be clearly identified as a short-term screening and connection program. It is not ongoing treatment. Instead, we try to mobilize the ongoing community resources to provide the treatment. The community provides those resources over time. So that's another lesson learned about, is to be very clear in our goals, both for individual nurses who sometimes want to become long-term case managers because they become attached and fall in love with families or realize the family needs, but that needs to be short-term, as well as the community recognizing that this program doesn't solve on its own solve all the needs. The community has to rise to the occasion. Questions about administrative home. We've been in the health departments, we've been in private nonprofits, we've been in hospital-based, we've been in private for-profit health service systems. And the last point is about financing. This is a struggle. Who will pay for this? In Durham, we are funded by a direct allocation, partially from the Durham County Commissioners, which is absolutely fantastic, supplemented also by private foundations. We do receive some Medicaid reimbursement at a small level. And in different communities, it's in different ways. So I think it's possible, and I'd be happy to talk with you about your community. And let me stop at that point.
Good morning, and thank you for having me. Happy to be here to talk to you about this program. First, I'll tell you a little bit about First 5 LA, who I represent. First 5 LA is a child advocacy and early childhood funding organization. We invest in initiatives for children aged 0 to 5 and pregnant women. And First 5 LA exists because of a tobacco tax, one of several tobacco taxes in the state of California. So we have a counterpart in every county, and all of those counterparts investing in early childhood. So to just give a little bit of background about how we came to a place where we had the Welcome Baby program. About 5 years into the life of the commission staffed up in 2000. We were reflecting on our investments to date, and we decided we wanted to invest in an ecological model. We wanted to look to the various environments that were impacting the child's development, very in line with from neurons to neighborhoods. And inclusive of that was this wanting to invest in the primary relationship that affects the child's development, and do it from a public health perspective with in a county where we have about, at the time, almost 150,000 births a year. Now we're around 135,000 births a year. It is hard to find families. So hospitals were an attractive point of contact for families. It allowed us to reach families that were difficult to reach with the types of investments that we had made in the past. And so we wanted to couple this public health approach with a place-based approach where we were investing, those communities were also building their capacity to meet families' needs, much as Ken discussed around how the community can come together to make changes that impact the child's development. So the objectives of our program are very similar to Durham Connects. We want to promote bonding and attachment. We want to improve the home environment, both the safety and ensuring that the environment is stimulating to the child's development. We want to link families with community and social supports, promote their use of preventive health care for both the child and the mother, and provide breastfeeding supports. So the program is also universal. Now, in context to Los Angeles County with the large population we have, universal right now for us is defined by universal within the hospitals that participate. We have over 60 birthing hospitals. We work with 14 of those. Those 14 deliver about 30% of the babies in the county. The program is prevention-oriented, client-centered, and strength-based. If you look to the right of this slide, you'll see the points of connection with families. So there are 9 contact points. 7 of them are in the home. 1 is a phone call, and 1 is in the hospital. And the families are interacting with 3 professionals throughout these visits. One would be the parent coach who's delivering most of the service. They're also engaging with a nurse at that first postpartum visit, which is intended to occur within around 72 hours after discharge, and that is so that the child could receive a physical exam, and if the mother is in need and wants a physical exam as well to ensure that she's healing properly, that can also be done. And finally, the families engage with a hospital liaison at that hospital. And the hospital liaison is this visit occurs much like an interview, a motivational interview, is very strengths-based and friendly, but at the same time, while they're doing that interview, they're ensuring that they check in on these 26 risk factors so that when we're done with that visit, we have an objective understanding of the level of risk that the family is facing. And based on that level of risk, it allows us to guide what kind of service we offer to the family. So this gives you an idea of what happens with the families once we go through that risk screening. Best Start communities are the communities that we invest in, 14 in LA County, and they were identified based on clusters of poor child outcomes. So they can be considered high-risk communities. So you'll see here, if you look in the top left corner, if a family is both high risk and coming from a high risk community, we're going to offer them what we refer to as Select Home Visiting Program, which is our shorthand for intensive evidence-based home visiting programs. Specifically, we contribute to the constellation of programs, an investment in Healthy Families America and Parents as Teachers. We also refer to Early Head Start and Nurse Family Partnership when a family is eligible for one of those programs. If you move to the right, if that family is from a Best Start community, but according to the Bridges screening tool, that's the name of the screening tool we use, they are low to moderate risk, we're going to offer them the remainder of the Welcome Baby program. Now, they may have enrolled prenatally, they may not, depending on whether or not we were able to find them prenatally, but we would offer the remainder of that program. And then the non-Best Start families, if they are screened to be high risk, we will offer 3 postpartum engagements in addition to the hospital engagement. And this is a low dosage for a high-risk family in a non-high risk or potentially non-high risk community. And that really is a reflection of just the minimal resources that we have available to serve families. But we really use those engagements to make sure families are embedded in whatever resources are going to support them in the long term. And then a low-risk family that is not living in a Best Start community would not be offered any additional resources. Particularly, we would, of course, make sure families leave that hospital with whatever resources they may need. This is the same information, just presented slightly differently, just to demonstrate that in that top box, what we're doing is we're reaching out in prenatal care environments to find families in our Best Start communities to attempt to provide some of these home visiting services prenatally. We still have a relatively low prenatal enrollment rate. Of all of our families in the program from Best Start communities, about 1/3 of them we are able to work with prenatally, and 2/3 we enroll at the hospital. So, what were the steps that we took to build the program? We started with a pilot in 2009 in one of our central hospitals in LA County. From there, we refined the model through the learning of the implementation in that pilot setting. And then at the tail end of our 2010-2015 strategic plan, when we had learned enough to feel comfortable, we expanded, not only expanding to additional hospitals, but we also ramped up those select home visiting models, the Parents as Teachers and Healthy Families America investment. We also had one small PPP program, which was for families, because they don't have an infant curriculum, was for families that had older children that families said they were struggling with the behavior of that child. It was underutilized and we closed it, but there are other PPP programs in LA County to refer to as needed. We also established a fidelity framework, and we're at this time learning about that framework to see if it's sufficient to ensure standardization of the program. And we've also included in that the client-centered approach, which is, we hope, an addition to the field, in that we're trying to understand if we can really standardize that approach and learn what its impact is on outcomes. We also established a research agenda during this period of time, and then when we wrote our 2015-20 strategic plan, we extended the life of this investment. This just gives you a visual on the ramping up of the program. As you can see, in 2013 through 2015, we brought on 13 more hospitals and are now working with 14, ramped up those HFA and PAT programs, and developed a database. And our database is meant to support program implementation as well as our research agenda. And in terms of who we've served so far, starting with training the staff who serve the families, we've trained over 600 staff and have had some turnover. So there are currently over 475 staff in both the Welcome Baby and the Select Home Visiting models, providing services to families. We have, in the last 2 fiscal years, enrolled 3,400 clients prenatally, 23,000 at the hospital, and we've made over 2,000 referrals to our Select Home Visiting programs. This is a visual of that. As you can see, so the pink bars are fiscal year 14-15 and the purple are 15-16. So you see that we're really in a ramping up phase where we're enrolling more families every year as the hospitals are able to further embed the program into their environment. And what this shows you is just what the take-up rate is once we make a referral to an intensive program. And though it looks like a bigger difference than it is, about 96% of the families receive that referral and follow through in participating in that intensive program. So moving on to our research agenda. We started with an evaluation of our pilot, which took place during 2011 to 2014, with a comparison group that received Welcome group and a group that received Welcome Baby. And they were delivered during the same time period as the treatment group, and they lived in that same target community, that central community in LA County. And then we followed up with families at the child's 1st, 2nd, and 3rd birthdays. So the study procedure included a verbally administered survey, observational assessment of the parent and child and the quality of the home, and at the 2nd and 3rd birthday of the child, a height and weight assessment. This study was conducted by Urban Institute and UCLA. And some of our findings included that the outcomes associated with participating included that mothers were more likely to breastfeed and be exclusively breastfeeding at the child's 4th month. There were higher quality home environments and more learning activities going on in the home, and stronger communication and problem solving skills in children. And that was using the home and the ASQ to conduct those studies. We also wanted to look at comparison between, in addition to comparisons between the populations, we also wanted to look if there were any specific outcomes associated with prenatal enrollment or completion of the program. So participation in more Welcome Baby sessions was associated with an increase in the number of months a mother breastfed. And this is one of multiple gratuitous pictures of my children. And at 24 months, we found that the program participation was associated with higher quality home environments. Yeah, all right. I covered that one already, sorry about that. So outcomes associated with prenatal enrollment included more home learning activities, lower maternal stress, more outdoor play, and lower overweight and obesity, and stronger problem solving skills in children. And for those families that completed all of the 9th visit, the final visit when the child is 9 months old, there was more engagement and activities outside the home for the family, more responsive and encouraging parenting, and they were more likely to receive child care subsidies. So at the 36-month findings, there was an association with better communication and personal social skills in children, better social competence, more responsive, encouraging, and affectionate parenting, and more teaching behaviors by mothers. And the BITSI was added to the protocol at that point. In addition, There were lower amounts of maternal stress for those families who enrolled prenatally, and for those families who completed the visits, there was also more responsive and engaging and affectionate parenting, as well as more positive behaviors in children. So our research work is also supporting our sustainability work. So we are engaging with the Medi-Cal managed care providers in LA County and looking to what about this program may be of interest to them and meaningful to them. So this study utilized the participant level data from a subsample of women enrolled in the pilot evaluation, both welcome baby and comparison families. And the comparison sample was augmented for this study by including all women who gave birth in that area between January 2010 and June 2010 and could be linked to their child Medi-Cal records, but were not in the pilot study. And the Medi-Cal data was matched for the first 2 years of the child's life. So some of the results we found regarding mother, and these three are the three most critical points that the Medi-Cal managed care provider has raised to us, were that there were longer Medi-Cal enrollment for the mothers, so she's not dropping off of care, that the mother is more likely to have postpartum visit within the HEDIS timeframe, which is the healthcare effectiveness data and information set that they measure their progress on. And mothers were less likely to have a subsequent delivery covered by Medi-Cal 2 years postpartum. So these were found in our population and are significant to that provider. The results for children include that they have the higher number of their well child visits, also an important measure for health insurance providers. But they also did have a higher number of emergency department visits in both year 1 and 2. This is something we need to study further because, as you've heard from Ken, that's not necessarily a goal, but we do want to learn more about how we're going to identify what is a necessary versus unnecessary hospital visit and what our impact is on it. So this is something we'll be studying further. We're also doing a psychometric study of the Bridges screening tool. This was a tool that had been used in a neighboring county for 10 years, but because our program was slightly different, we needed to change some of the measures on the tool, so we needed to retest its reliability and validity. We just received our reliability findings and found that there's good inter-rater and retest reliability, and our validity results will be coming in the fall. And this is being conducted by RAND. RAND is also conducting our implementation and outcome study, and this is an opportunity for us to learn about how the program is doing, particularly around fidelity. How are our partners doing in terms of maintaining fidelity to the program? What are the quality and breadth of our referrals that we're making out into the community for families? What is the participant experience? And what are the factors that cause families to attrit from the program? And the extent of short and intermediate outcomes that we're seeing. And this is scheduled to be completed late next year. And finally, and very exciting for us, and the first type of study like this that we've done at First 5 LA is that we're engaging in an impact study with a rigorous study design, likely a randomized control trial. And this is where we really want to make sure we understand, is this program effective? Do participants have better outcomes than similar non-participants? Do women of varying risk levels benefit from the program in the same manner? Does this impact various subgroups? We have a very diverse population in LA County, and we want to make sure that we understand how the program affects those populations if the effects are different. Is prenatal enrollment associated with enhanced outcomes? As I mentioned, our prenatal enrollment is low, so it's really important for us to understand what those prenatal engagement points, how they're impacting families. And this is scheduled to be completed in late 2019. So some of our lessons learned. Partnering with hospitals for us in LA County was very difficult. It was a huge culture shift. One of our partners who does technical assistance in the hospital said, as opposed to other units in the hospital, birthing babies, there's not much new under the sun. So their protocols are pretty set in stone. Change is difficult for them. So they've sometimes tried to medicalize the program. We've struggled to always have a champion in the hospital to make sure that the program is running smoothly and is integrated into the labor and delivery unit. We've made a lot of progress in this area, but it has been a challenge. Systems building. All of the programs are on one database, and they need to make referrals between one another for different reasons, and this was a culture shift for the agencies. About half of our hospitals have a subcontractor that's a community-based organization doing the home visits, and they're just used to being individual programs who, this is my client, and to it was important for us to build relationships between the Welcome Baby providers and the select home visiting providers so that those Welcome Baby providers felt comfortable making that referral and therefore accurately completing that risk assessment. Also, recruiting and serving diverse populations. We're doing pretty well with our Latino and Black population in LA County, but we have a number of Asian Pacific Islander populations that we are not being very successful at recruiting and enrolling, and we're working very intensely on that issue now. The importance of training and technical assistance, we've invested quite a bit, about 10% of our investment is on training and technical assistance. And the Welcome Baby providers receive over 150 hours of training, and they have found this very valuable, and they have ongoing training and technical assistance. We look closely at their metrics and see what needs to be improved and provide that service. Data system design and implementation. Everyone wants to run a program a different way, so the data system makes, any given module of the data system makes somebody happy and somebody else unhappy. So it's a constant negotiation between all the providers. And of course, the limitations of public funding. First 5 LA is a declining revenue. We have less smokers in California, gratefully, but it does mean we have less resources to continue this program over time. And some of the early indications, first, that we are pretty early into our implementation, given that those 13 hospitals we brought on later are pushing up on a 70% acceptance rate. It's pretty comparable to more mature programs. So we're feeling that universal approach does create this lower stigmatization and encourages families to utilize it. There's also a word of mouth and people are very happy with the program. So we're getting take-up rates growing. We have a longer opportunity to do ongoing risk assessment with the family and in the home, and that gives us an opportunity to identify issues that didn't crop up at the hospital, which is given a challenging time to interview a family when they're in a very unique moment in their life. And finally, one of the changes we made that was really important is that women who were in the Welcome Baby program that were offered the intensive home visiting program were, for some time, there was a portion of women who were saying no because they understood that if they stayed in Welcome Baby, they would get a visit from a nurse, and that was very valuable to them. So we went back to our board and we said, we have got to offer those moms that nurse visit before enrolling them in the select home visiting program, and our board agreed. And that made a significant change in women who really benefit from that longer, more intensive services, getting those services. What we were finding was often that those women who stayed in the Welcome Baby program that were high risk, when they got to 9 months, both the family and the provider were often very concerned about ending the service. So this has resolved that program to a great extent. And with that, I will turn it back over to Rachel, or to Deb.
I know you have a lot of questions. I'm going to keep my remarks short. I want to thank Ken and Barbara for their presentations. This is an intervention that is something that I totally believe in. I need to be truthful with you. I think this idea of universal home visiting could be a game changer. It's a way of adjusting the platform. It's a way of thinking differently about what kinds of support we provide newborns and their parents. Both of these programs have demonstrated that this difficult task can be done. Both of them have benefited, and I don't want to skirt over this, the advantage of having funders with the foresight to invest for a period of time and allow them to fail so they could ultimately succeed. So, and then they followed very different paths. Ken's program is much more along the traditional lines of what you would do if you were following a clinical demonstration program. Those folks in LA, brother, they just went for it. They've developed quite a wide range of service delivery, but I think with a real intention to always learn as they go, and are now in a position to do a really strong, successful evaluation of their efforts. I think both of these programs, while they've demonstrated that it can be done and that it does work in certain circumstances, they've also demonstrated how challenging it is. We're seeing that outcomes are not universal across all populations in all circumstances. We still struggle with how does this work best for whom, under what conditions, and what do we need to do differently. They probably struggle with issues of fidelity and understanding exactly what should be done and how consistent should you be in delivering the service. When do you vary? Because we know that families differ. And certainly the issue of finance. This is an important issue somewhere along the line. the dollars need to be found to shift into what I think is a more promising practice. Personally, I think we do have a lot of money in public systems. We spend a lot of things on things that don't work. If we were to redirect those monies to things that show greater promise, I think we could indeed find greater success. What I want to focus my comments, though, is a little less on the programs themselves and more on this idea of how you promote a public health response. Public health is different than individual health. Public health, the health of the public, the health of the population, the health of the society. And there are a lot of barriers in trying to do public health planning. Henrik Blum, who's really the father of health planning, said many years ago, it's not the special interests. That's really not our concern. What gets in the way of planning public health, it's determined by such societal forces as our traditions, our socioeconomic political outlooks, our formal governance structures, and the availability of resources. In other words, it's how we frame the context that shapes how we do the planning. And for my sense is that's really the question that we need to ask ourselves. How can we create a context that is more hospitable to successfully supporting newborns and their parents, all newborns and their parents, all children, regardless of their circumstances? The concept of universality, I think, offers assistance in achieving this goal. It's attractive for several reasons. First, what I love about it, it gets us out of the mindset, both of these programs do, with the notion that if we just found that one right program, brother, we'd be home free. It's not about one right program, just as it's not about one right thing or wrong thing you do with your kids. It's a constellation of events. And for communities, it's a constellation of services. And if they're not working together, if they're not pulling in the same way, if they're not complementing each other, it's going to be almost impossible to achieve those outcomes we most desire. Second, I think it builds a service delivery structure that gathers multiple choices and interests into a collective call for change, and Ken talked about that. It's not about finding what one family needs or two families. It's about, imagine if you find about what 1,000 families are thinking. That if you can galvanize that, you do create an opportunity to move this debate into the public square more effectively. Third, I think it creates a response system that really is shaped by what families say. We give a lot of what do we say? We give a lot of attention to raising the parent voice, to listening to parents, but often in our planning, it's done by experts, so-called thought leaders, that think they know what families need. This is a way of saying, what are families telling us at this moment in time they need, and then how do we go about meeting that need? It really elevates the parent voice to a position I think it needs to be. Fourth, I think it creates a context in which all children are assumed to be in need of our collective investments. Children aren't singled out for concern based on the fact that only poor children need collective concern because those poor parents can't care for their kids. The reality is, in this country, millions of poor parents get up every morning, working class parents, do a great job with their kids. And they do it because they've got a lot of resources, because they set the priority of their children high. That we need to understand that when we segment those out, when we say that only some parents struggle, we do a disservice to all parents in many ways. Nothing in the model of universality, and both of them have talked about this, suggests you offer the same thing to everybody. This isn't a vaccination at a single dose. It's really trying to be more efficient in how you allocate resources so that you see families get the level of services they need. That we recognize the fact that unless we offer services to all families, we're going to continue to set up a dichotomy between those that can and those that can't. Some say universality is too costly. I think both of these models suggest that if we did it and we did it right, we would in the end save money. Offers of assistance that are only made to poor families, minority families, or some segment of the population rarely are strength-based at the end of the day. They're often punitive, and they're viewed as stigmatizing by the very people we're trying to help. They reinforce a stark line between parents that can meet their obligations on their own and those that cannot, contributing to what many of us are concerned, particularly at this point in time, with a coming apart of this society. The fact that people have more differences than they have things in common. If something like prevention can't bring people together and be implemented in a way that does bring people together, create a sense of common ownership and responsibility, I think it'll always be limited in what it can achieve. Universal strategies, I think offer us an opportunity to avoid the very outcomes we're concerned about, be it child maltreatment, being the absence of school readiness. It will provide more families with the level of services at the level they need. And I think it'll generate public will to make the kinds of investments in services for kids that truly can meet the needs of those children most disadvantaged. Thanks.
Sorry about that. Now it is your opportunity to engage in discussion, but before we take your questions, I want to take one more opportunity to thank the presenters today, not only for their presentations today, but for all of their work. Thank you so much. Okay, we have microphones in the aisles, and please use them.
We have a question in from the live streaming audience. We'll imagine thousands. They were interested in Dr. Dodge's explaining further how they're selecting the expansion cities and what those communities are committing to for that expansion.
Yeah, thank you for the question. We have responded to inquiries from communities across the country. We've not proactively pushed out the program in any advertising way. When we receive an inquiry, usually it's by telephone or email, and we set up a telephone. We talk with the community. We have not rejected communities yet as being not ready or not able, but a number of communities have self-rejected or realized that they're not ready, or they don't have the resources, or they really wanted us to collaborate with them in writing a grant to get the resources, or for whatever reasons they can't do universal. They really want to restrict it to a subgroup, and so they've pulled themselves out of the running. I think that's the way we'll go on for a while. We're struggling with setting up a dissemination infrastructure and office. As I said, we're in 12 communities now. We should add another 12 communities before the end of this calendar year. And I think very plausibly add another 50 communities in 2017, but we'll see how it goes.
Can I just follow up on that question a little bit? I'm curious, what are some of the key elements you think are necessary for success? I understand you're not, but clearly you're learning a lot along the way. What are your hints? What are your guesses?
So at the moment, and this is different from the longer term grand vision that I might learn from Deb, who thinks we're going to conquer the whole world, and life will be different. For the moment, the key questions for us are first of all, having a definable community where we can capture all births and we can define the community resources for that community of a manageable size. I don't think we're ready to do all of New York City at one time. Just, no matter what financial resources, just defining that. Could we do a borough or a neighborhood? It would depend on whether that neighborhood functions as a community, or is it the case that families within that geographic community are still receiving services in 50 different other communities. That would be very difficult for us to align all of those agencies. So having a definable community is an important point. Having community leaders who align with the program and want to engage the program, since the program relies so much on collaboration with those communities. Financing is necessary of a long enough period of time. We've had a community say, well, we've got this 6-month planning grant, can we try it out with several hundred families and then we'll try to get more money later and all of that. And we've said that's probably not the best way to go about it because we don't want to get hopes up and then fail. So a little bit longer sustained funding. We have not restricted ourselves regarding the demographic makeup of a community so far. I suppose there are well-heeled communities in this country where it might not make sense, but we haven't found that yet.
Yeah, sure.
I was wondering
this-
if Barbara wanted to add something.
Sure. This is sort of a dry answer, but I think when you're implementing a brief program, it's even more important to have a fidelity framework and be standardized, because you have to know what your inputs were, and so that's really critical. And then kind of in addition, on the sustainability front, it's a challenge to ensure that the systems that benefit from the program recognize that they benefit. So you have education, you have health, you have child welfare, and it's difficult to knit together sustainability when everyone's sort of benefiting from that program. A portion of the program is benefiting multiple systems. So it requires knowledge by policymakers that have influence over all of those systems.
Hi, Helen Rakes from the University of Nebraska. First of all, thank you so much for this excellent panel. It was really, really wonderful in all respects. My question kind of follows up on Rachel's and the earlier question to Dr. Dodge. And it seems to me this concept of universality is particularly well suited to rural communities, where services and experimentation is often left behind. So I wondered if you could comment on your expansion communities, if any of them are rural communities explicitly, like under 25,000 in population, or if any of the potential expansion communities are rural communities.
Yes, a number of them are. We are in 4 different counties in eastern rural North Carolina, which I'm told, if it became its own country, would be one of the poorest countries in the world. So the resources are very limited there. We have been able to implement successfully in those communities. As I said earlier, the community resources differ. Fewer professional resources, more natural, paraprofessional, community level resources. We've had great support in those communities from physicians. So a mother might live 50 miles away from the physician's office and can't really easily follow through with the regimen of well baby care that's prescribed. And so we can supplement that in our home visits. So we do some medical checks and interaction with them. We're also in rural communities in Minnesota, some small counties there administered by the health department. There is a cost issue, just a base infrastructure that's necessary that might make it more costly per family in a rural area just to have that infrastructure and the supervision and of course the travel time and all. But I don't think it's insurmountable.
Thank you for that question, Helen, and that's also a good time to make a little plug for the plenary tomorrow morning, which is specifically geared to talk about, Helen will be presenting, about services in rural communities. Thank you.
I just wanted to ask a question and then make a comment, and I'd like your reaction to it. One is, if you could just say a little bit more, and I think in both the models that we saw today, about the family and community engagement aspect. And I know with what you were doing in North Carolina, you have these community boards, and kind of where do they come from, and how do you bring people into that, and a little bit more about that function. But I was listening to Dr. Daro's comment about, in some ways, universality. One of the benefits of universality is that we can truly get what the whole community thinks and reacts. Like, you put the service out there for everyone and we don't like it, that really tells you a lot about what's wrong with that. Whereas if it's too targeted, sometimes that piece gets lost. And sometimes I think in families of lower income, the ability to engage them is harder, and therefore you're not getting the feedback from your clients that you really need in order to improve your services. So how does how has that worked out, that universality piece, in terms of being able to engage community and families, and then using that as a quality improvement piece and an improvement of both services and outcomes?
Sure. So we have a pretty high rate of completion of our parent satisfaction surveys, so I'll say that first, and we take those very seriously and use those to improve the program. But we also, the place-based effort Best Start, which started technically at the same time as the Welcome Baby program, but actually had a rougher start. It was sort of a unique fit for the type of organization we were, so it took a bit to get off the ground, but now it is much further off the ground. And what we do is we require our Welcome Baby sites to go to the partnerships that lead that Best Start effort, and they are required to give status on how the program is doing, who they're serving, and that those partnerships have a say in multiple aspects of the program. For one, those partnerships chose the intensive home visiting models. And they did that by looking at data about their communities and talking to the families that were involved in the partnerships, say, what does our community need? So some of them chose one or more of those models for that reason. It also gives an opportunity for the Best Start Community Partnership to hear what's being raised by families as issues that they can address at a community capacity level, similar to what Ken spoke about. So we're looking right now to really enhance the engagement between those aspects, because our Best Start communities are becoming more robust and are really coming into sort of their influence in their community. So we're finding that there's a lot of crossover where families, in our 24-month study of the pilot, we were happy to see that families were engaging in the community more, because that's what we encouraged them to do in the Welcome Baby program. And now there's more to connect them to, now that our Best Start communities are coming up, are growing in their abilities. So hopefully that answers your question.
We've spent a lot of our time interacting with our community agency leaders and trying to understand what they do well and how we can help. We began with a small group of community leaders. We call it the Wednesday Morning Breakfast Club. They'd meet at our place on Wednesday mornings. This was no more than a dozen people, but it included the school superintendent, the health department director, the elected chair of the county commissioners, the head of our Partnership for Children, which administers early child care programs, et cetera, and collaborated with them and really had this effort be a community-owned effort. We learned that we could be seen as a competitor to some community programs, Healthy Families, Early Head Start, or whatever. Welcome Baby, the Welcome Baby organization within Durham, had a hospital visit at birth effort that was really a low frequency. They saw fewer than 10% of all births before we came in. And so it was kind of a random effort, but it was one of the things that they did. But we interacted with them, not in a competitive way, but in a way to try to support them. They also have ongoing parent support groups, and they have other kinds of programs for families. And what we were able to do is actually to understand what kinds of clients they sought for those programs, and then we could refer families to them. That's what we found with a lot of agencies, that many community agencies that serve families birth to age 5 do not want to be in the business of case finding. That is a costly business. They do not want no-shows. They do not want referrals that are not appropriate, maybe either too psychologically impaired or not enough psychologically impaired for what level of intervention they provide. So we really came to be known as the program that would help programs rather than a competitor replacement. So within Durham, we are the single largest referral source for Early Head Start. We are the largest single referral source for Healthy Families Durham. We provide a lot of support to child care agencies in working with them and helping get families connected with them. We work very closely with the Division of Social Services in getting families emergency housing loans, child care subsidies, et cetera. In fact, where we have the forms and we're really almost an agent of them if they want. They in turn have changed their practices now and can devote their attention to seeing more families rather than having these no-shows and poor fits case finding that take up a lot of dollars. So in that way, I think we've really aligned with community agencies, and that's extremely important going forward to any new community.
There's a lot of concern about homeless, highly mobile families across this country, and it strikes me that you're in a very good position, both of you, to comment on how you've addressed this issue and how this kind of program might actually be helpful in coordinating with residentially unstable families.
Yeah, sure. Well, first of all, if a family is homeless, we still serve them. We meet with them wherever they're comfortable meeting. And we are able to, among other things, provide data to the policymakers in LA County about how the housing situation of families, which ranges from, in LA County, very poor housing conditions to no housing at all. So we've been able to provide that data, and we work very closely with our county our Board of Supervisors. The Board of Supervisors chairs our board. One of them does every year. And they're now in an intensive push in LA County to pressure the governor to declare a state of emergency over housing and to look for taxing options to support housing. So, and this is a similar situation with other issues besides housing. We've created some pressure around services for maternal mental health issues by raising the data that we are getting out of the system. We're very early in this phase of being able to get data out of the system, but I think it's one of a universal program's greatest contribution. Because you're seeing so many families, you're able to say to policymakers and other types of providers and systems in whatever area you're working in, here are the primary issues that families are dealing with.
In Durham, this is a problem and a challenge that we are uncovering and learning about, and are by no means expert about how to solve it. We need your help, Ann, so you need to come to Durham and interact with us. We do meet families wherever they want, and so we've had certainly some homeless families who will meet with us at the home of a relative, or will meet with us at the pediatrician's office. And of course, the homelessness becomes the focal point of what we're interacting with them about. So we then interact with community agencies. Genesis Home is one in Durham, several other homeless shelters, and connect families in those agencies. But I don't have clear answers on how many of our families are homeless, because they hide it and we're not sure. And I don't know the best way to go about approaching those families and interacting with those families.
I was interested in noticing that breastfeeding was an outcome measured in LA, presumably because of the benefits connected to attachment and health and obesity prevention. Was breastfeeding an outcome measured by Durham Connects?
In our first randomized controlled trial, it was an outcome. We did not have a significant impact on breastfeeding. Breastfeeding, we have learned in Durham, is a growing interest, and we are paying more attention to it in our intervention now than we were initially. But at this point, we don't have a significant impact on improving breastfeeding.
Thank you. Do the two of you have an explanation of why it would be, in
maybe,
LA, but not?
Maybe in our first randomized controlled trial, we didn't explicitly attend to it enough. And second, there may be community cultural differences in California and North Carolina. We encountered some mothers in North Carolina who did not want to breastfeed and actually railed against breastfeeding, particularly young mothers who were concerned about the rest of their lives outside of their baby.
Thank you.
Yeah, all of our home visitors and our hospital liaisons and nurses are certified lactation educators. So I don't know if that's part of the training or not.
Now it is.
Yeah, so it's been a focus from the beginning, and we also do have populations that are relatively resistant, particularly in LA County. We have a lower rate of breastfeeding in our African American population, but all areas are increasing. In California, we also about 2 or 3 years ago passed a law that requires the hospitals to either seek baby-friendly hospital designation or something similar. All of the Kaisers in California have already become baby-friendly, and we actually fund baby hospitals to get their baby-friendly designation. So there's also other contributing factors besides just the home visiting. There's the support that's going on in the hospital.
Oh gosh, Rachel, this is like a. Okay, I asked Rachel if I could ask a question. One of the things we know from the intensive home visiting research is that enrolling women prenatally intensifies impacts. It's really good. This is both of these primarily are drawing their families at the time of birth. So I wanted to ask each of you, what if you were trying to expand to a prenatal population, what would that look like, and where would you go to find them?
So what we do now is each birthing hospital, our oversight entity, which I didn't speak about, this is our entity that helps us with standardization, training, and technical assistance. What they do is they take the information about where the family received prenatal care, and they rank it just simply where did most of our families receive, and just rank them. And they have outreach specialists which go to those sites and ask the physicians and the staff at those clinics and practices to enroll families, and they also allow time for our outreach specialists to engage with families directly. So it's just a matter of taking time. Doctors' offices, clinics are busy places, and getting them to see this as critical to their work is an ongoing challenge. We have pediatricians who are very interested in knowing that their families are in these programs, but it's a little bit harder with the OBs who we really need the referrals from. So that's what we need to continue to do to enroll more prenatally, and it's increased, but it's a slow slog.
That's a great question. The vision that we have is that we will have communities that provide support throughout the lifespan, beginning prenatally, if not before, as well as at birth and in early childhood, across birth to 5, and throughout the lifespan. So we have been thinking about how to reach families prenatally. I don't think we create a new community agency, but we work with existing ways of identifying families. So that may be OBGYN practices, clinics, word of mouth, anywhere you can find them. We haven't identified a way to make it as exhaustive and systematic as we can at birth, where at least at birth there's a birth record, and there are hospitals, and at least in North Carolina, over 90% of the births occur in those hospitals, so we can reach everybody. But that doesn't absolve us of the need, and I think you're right that if we reach families prenatally, we can have greater impact. We can get father involvement, we can help mothers engage in better quality prenatal care. We can probably make a more straightforward financial case by preventing low birth weight and intensive care outcomes at birth. So I think, again, it would be working with those community agencies, but here it may be more practice groups like the OBGYNs. We're also piloting, by the way, a brief home visit program at age 12 months. So in our communities where families receive the Connects program at birth, we stop and we send them on their way, but we are now piloting a plan where we stop seeing them, but we stay connected to them, and we come back on the baby's first birthday, maybe with a present in hand, with a new home visitor and new assessments of needs, because new needs arise. Assessment of risk is not static, right? And the baby's needs change, and the parents' needs change. So we're piloting that now and planning to have to develop a full-blown program for age 12 months with some sort of connection between birth and 12 months, maybe through hotlines, maybe through pediatric care, so that the support could be a bit more of an ongoing nature.
Thank you for your presentations. Really tremendously valuable information that you're sharing. My question is around staffing and ramping up to be able to provide the range of services that your home visitors are providing. Because if they're dealing with things like child welfare and homelessness, but also well baby care and typical kinds of parenting needs, it's really a wide range of skills that they have to have and competencies. And I know we're looking a lot at the infant mental health endorsement as a way, a kind of a foundational piece. But I'm wondering if you could just maybe describe the kinds of things that you think are essential elements of professional development and competencies for your staff. And maybe speak a little bit to how to get those skills in the timeline that you need them to be able to implement.
Yeah. We, before we began, we actually piloted different professions in doing home visits, and we had focus group with parents, and nurses were universally accepted around the time of birth. Nobody, very few people would reject the idea that a nurse might come to your home at age 3 or 4 weeks and weigh your baby and help you realize that yes, your baby's still alive and doing well or not. Social workers are a particularly difficult group for families to embrace at birth because of the fear that we're trying to identify child maltreatment. But social workers are an important part of our team, and so we have evolved to work in teams. So initially it was just the nurse would do everything. And the nurse is expensive, and there are not a lot of them, and the expertise that we need really goes beyond that. So we now work in teams. The nurse will do the initial home visit, but maybe somebody else in the team. We have social workers and bachelor level paraprofessionals in our team. So the nurse might say, okay, I'm on the phone, we've got an appointment on 2 p.m. Next Tuesday for you to visit this child care agency, or whatever, can you get there? No, well, I'll have somebody come and pick you up from our team. Ms. So-and-so can be here at 1:30 and we'll get you, and she can take care of your baby while you're doing the interview. So the nurse has a team around her. We also rely on collaborations with ongoing community agencies. So the Division of Social Services has the expertise in all the array of, I think there are 38 programs in Durham that the Division of Social Services administers for families birth to age 5. These are silos of programs, right? Child care subsidy, emergency housing loans, you name it. And so we work with the expertise within that division. So we're not employing them, but we're on the phone, we're visiting, we're interacting with them a lot to try to broaden the reach and broaden the expertise.
Most of our parent coaches are bachelor's level helping professions, including social workers. They don't refer to themselves as social workers, they refer to themselves as parent coaches, and it hasn't been too much of a problem. Again, nurses were definitely prohibitive for us because of not only the cost, but the shortage of nurses. So having that one visit allows us, we were able to recruit enough nurses to do the one visit, and that's actually a challenge. We are often short a few nurses at any given time, and we do have some non-bachelored parent coaches, but they tend to be promotoras or health, what do you say in English? Community health workers that are have a lot of experience, but they did tend to require a little bit more training and technical assistance, even with their experience.
We have time for one more question, and I know there are two of you, and this is really hard. Okay.
I just wanted to mention that in the last question made me remember that I read this article maybe yesterday in the New York Times about Finland, Welcome Baby program, and you had asked about prenatal care, and I think it's like as a reward for a certain visit that they attend, that they get this welcome box, which includes like this cardboard crib and all these sort of goodies. And I guess I just wanted to ask, is there sort of like a goodie component to this? Because I would imagine that would be
We certainly
enticing.
bring a goodie bag for the at birth home visits, with diapers and some lotion for the mother and a thermometer. It varies. We get local corporate sponsors or people to pay for those, but it certainly helps.
Yes, we do. We have, first of all, in the state of California, we have the First Five California, our counterpart at the state level, creates a parent kit. So they get the parent kit, and there are various incentives at every visit. One of the favorites that the moms receive is actually the boppy. For those that are, even the ones that aren't breastfeeding, love the boppy. So that's one they're pretty excited about, as well as books and other safety items. So items for making the home safer for baby. So there are various incentives at just about every visit.
You go ahead. One more. That's the last one.
This is for Dr. Dodge. I'm just curious to hear if you've made any inroads or any outreach to midwives and home birthing kinds of options.
Yeah, we have. In Durham, midwifery is not a high proportion of births. But we have, and in other communities where it is even more common, it is a terrific relationship to develop, and then we figure out how to engage the mother right after birth.
Well, we've reached the end of the plenary this morning. Thank you all so much for your attendance and your attention. And have a great rest of the day.